Good day, I'm Pam and I'm going to discuss on situated learning theory.
I'd like you to meet Maria. She's a new clinical clerk on her first day of her entire clinical rotation and assigned at the pediatric ward. Her heart races as she steps into the busy hospital floor. Her resident asks her to take a patient history on a 6-year-old girl holding her mother's hand. Sitting by the bedside, Maria realizes no textbook could prepare her for the emotions, the unspoken cues, and the real-life challenges. Today, she's learning directly through experience, an example of situated learning in action. What is situated learning theory? It's an instructional approach that emphasizes creating meaning from real-life activities. It was developed by Jean Lave and Aitken Wenger, building on ideas from Dewey and Vygotsky, who emphasizes learning through participation in communities of practice. Enhanced learning is through active context-driven learning. It also includes the community practices where learning occurs within a community where individuals engage in shared practices. Newcomers learn from experienced members through observation and interaction, moving from peripheral to active participation. Knowledge is constantly evolving and tied to specific contexts and social interactions. Students learn more effectively when they actively participate in meaningful context-driven experiences, meaning the setting and environment they are in. Knowledge acquisition is part of culture and context in which learning takes place. According to Lave and Wenger, learning is inherently social and context-dependent. They believe that knowledge is not acquired in isolation, but through interaction with the social and physical environment. So why does it matter? When students are actively involved in learning through hands-on practice and real-world scenarios, they're more likely to retain information and understand its application. Engagement in authentic tasks that mirror real-life activities promotes deeper understanding and skill mastery. Let's look on some examples. In medical education, students learn through clinical rotations, treating real patients rather than simply studying cases in a classroom. Engagement in authentic tasks that mirror real-life activities promotes deeper understanding and skill mastery. Now let us delve further on the key components. Let's give an example on the authenticated settings where students gain experience during their emergency room department rotation. Medical students in this department work alongside attendees, residents, nurses, and other emergency room staff in a fast-paced, real-world environment where urgent decision-making is critical. And there are authentic learning activities like students observe and assist in patient triage, learning to quickly assess and prioritize cases based on severity, a skill that is crucial in actual emergency settings. Under supervision, the student would participate in making immediate clinical decisions such as identifying the need for imaging, labs, or emergency intervention, especially they are the first one to have contact with these patients. Next also is the interprofessional collaboration as the students engage with nurses, respiratory therapists, and other personnel. Learning the importance of teamwork in delivering cohesive patient care is developed during this rotation. They also encounter a wide variety of patient cases, from trauma to acute medical emergencies, allowing them to apply theoretical knowledge to real patient scenarios. This to enable students to practice skills under real-world pressures, preparing them to respond confidently and competently in future emergency situations that textbooks alone cannot provide. Now let's look on the cultural relevance during their community rotation. The cultural relevance would be integrating the specific values, beliefs, and practices of communities into learning processes. Examples would be when they do the rotations in this diverse community, they would understand how cultural beliefs impact health behaviors and patient care. They will also be able to adapt communication and build trust with patients from various cultural backgrounds. They would develop empathy and respect for cultural diversity, enhancing patient-centered care. They would be able to be prepared as healthcare providers in the future to meet the unique needs of diverse populations effectively. Another key factor, it has a social interaction. Case presentations with senior physicians during rounds would enable the student to present cases and receive feedback, improving their clinical reasoning through real-time mentoring. They will also work with nurses and other staff, which would teach these students about teamwork and the importance of each role in patient care. When they discuss with their peers, they would share knowledge and build a support network. And when they practice patient interviews, help students develop empathic communication skills tailored to diverse patients. There is also resident mentorship, where residents guide students in the procedures, fostering a supportive learning environment and reinforcing practical skills. These interactions immerse the students in a collaborative healthcare community, enhancing learning through shared experiences and real-world application. Now let us summarize the benefits for this learning theory. It can develop enhanced retention, as students better retain knowledge when they understand its practical application. Skills learned in authentic contexts are more easily transferred to real-world settings. There's increased engagement, as active involvement in meaningful tasks increases student motivation and engagement. There is also development of critical thinking, when situational learning encourages students to think critically as they navigate real-life scenarios. It also comes with its challenges. It is very resource intensive. It requires substantial resource and planning to simulate or access authentic learning environments. And not all students may have equal access to authentic context-driven learning experiences. There is also a need for instructor expertise, for they need to be skilled in both their field and in facilitating real-world learning effectively. There is also assessment complexity, wherein evaluating learning in real-world contexts can be complex and subjective. Now that we have an overview of situated learning, let us look on how we can develop classroom activities. Guidelines for instructors, as suggested by Stein, is that one should select realistic activities. Choose complex problem-centered scenarios relevant to this desired knowledge. And one should provide scaffolding or adjust guidance as students build competence in realistic tasks. And the role of the instructor is as a facilitator, tracking progress, assessing work, fostering collaboration, and encouraging reflection. The assessment would be focused on individual and community growth through discussion, reflection, and community validation.
Here is an example of a case study where there is improvement of diagnostic skills and development of professional identity. Here is a research done on nursing students where results showed better competence in nursing technical performance and competence scale.
A summary of the differences between situated learning and transformative learning. Together, these approaches prepare students to tackle complex real-life challenges with both competence and compassion, building healthcare professionals who are skilled, reflective, and responsive to patient needs. And here are our references. Thank you.